Thank you so much, John, for that introduction, and to Catherine for inviting us to speak today, and for the Kennedy Forum for putting together this panel. So I'm going to drill down into measurement-based care, which has now been mentioned by two of the previous presenters, to make sure that we're all on the same page about what measurement-based care is and how you can think about implementing it. So measurement-based care is the systematic administration of symptom rating scales, as well as using the results in order to drive clinical decision-making. And this is referred to at the level of individual patients. Now, it's true that you can use measurement-based care to aggregate the results of screening to understand something about populations or subpopulations in terms of their health benefit, but the actual measurement is at the level of individual patients. I'd also like to note a forthcoming publication that we have co-authored that will be out in Psych Services, and the citation is below for those of you that want to take a look out for that. So you may be wondering, don't we already use measures when we treat patients? Behavioral health care has been provided for a long time, and I don't see why this is something that's new. Well, in fact, only 17.9% of psychiatrists and 11.1% of psychologists in the United States routinely administer symptom rating scales to their patients. And you can imagine that if that's the case for specialty behavioral health settings, then what do those numbers look like for primary care? They may be using measures for screening, but not using them in a way that allows them to look at outcomes over time as they're using prescriptions and other interventions to manage depression and anxiety. So for the 80% of psychiatrists and 90% of psychologists, it goes a little bit like this. How are you doing? And the patient says, I'm good. But they may feel lost, alone, desperate. They may be experiencing worsening of symptoms, and that's really problematic if we're not able to detect that. Well, you might say, you know, if most care is being practiced this way, it must be right, it must actually be working. But in fact, we know that it's not. When we rely on clinical judgment alone, mental health providers detect worsening for only 21.4% of their patients that have increased symptom severity. So we're actually really poor at detecting when our patients are going off track. And that's true for specialty providers who have additional training and should be able to detect this. So it means that it's even more important for primary care providers that do not have that level of training to be able to have diagnostic clarity or to know just by the clinical interview if a patient isn't doing well. Together, these issues lead to clinical inertia that's really unintentional. It's not that providers are not trying to do the right thing. It's just that they don't have the tools that they need to know whether or not they should change the plan or should treatment stay the same. Common sense would say that if a person is not responding to treatment, you should change the plan. But this system and this practice leads to failure to detect treatment non-response and a resultant keeping of the same plan, despite the fact that the patient is not getting better or they're getting worse. So when you utilize measurement-based care approach, it has a very strong evidence in the context of collaborative care. Measurement-based care is a fundamental component of collaborative care. So we know from many studies that you find improved clinical outcomes when you're utilizing measurement-based care. It is acceptable to patients and providers. It actually promotes shared decision-making and engagement in care because the same information is available to patients and providers as to how the patient is doing and why I'm recommending an increase in medication or addition in therapy. And we also know that it's feasible at large scale. The studies have also shown that there are some ineffective methods of implementing measurement-based care. And the first is just screening and referral, which is probably the general usual care, primary care. You're doing depression screening. Oh, I see that you're depressed. Let me refer you to the specialty care clinic or provider. That doesn't work. It also doesn't work if you screen and then remind providers about clinical guidelines. You might think that that would work if they just tell the person, here's a reference, you should read it now to help you treat this patient. That also doesn't work. It's also really important that you are using the measure in a frequency that is enough to inform clinical decision-making. So there's a lot of great tools out there, but they're not utilized frequently enough to actually drive clinical decision-making. So if you're just assessing something every 6 months, but that measure might change more frequently, you're going to miss the opportunity to make a change. There was also a study where they gave feedback of the assessment outside of the context of the clinical encounter, and timing really does matter. So it's not as effective when the current recent assessment is not available at the point of care in the clinical encounter. We know that there are large-scale examples of usual care being transformed to be measurement-based, both in research as well as within the federal level. So 2 large-scale research studies, the STAR-D trial and the STEP-BD trial, were usual clinical care practices that were looking at differences in certain medication treatment regimens, and they utilized a measurement-based care approach. Subsequently, Kaiser Permanente and the Washington State large-scale implementation that you just heard of were also examples where measurement-based care was implemented. The VA, as you just heard, is using measurement-based care in their behavioral health lab within primary care to look at depression outcome change for primary care providers that are managing depression in their practice. As well as in the mental health service line, measurement-based care is utilized also to detect improvement. So there's an example of both in primary care as well as specialty care settings where measurement-based care has been used. In the Department of Defense side, they also had developed a behavioral health data portal for specialty mental health clinics, and it's also being incorporated into their integrated primary care setting in the DoD side. So in addition to the issue brief on collaborative care that the Kennedy Forum helped to produce, there was also a measurement-based care issue brief that you can download as well. And there was a couple of points that were specific to payers that I just wanted to share with you today. The first, Henry mentioned, is one of the main benefits is transparency. So now that we have the Mental Health Parity and Addiction Act, payers are being held accountable to offer equivalent benefits. And so this data can really be helpful when you aggregate the results across patients to make the outcomes more transparent and to allow payers to see the observed outcomes of treatments that they're now required to reimburse for. This will also help payers to make more informed decisions about value-based care purchasing, as well as help to develop and encourage smart provider networks. So then now that you have this data, you can use that information to identify where your higher performers are and what are they doing on the ground that's leading to that better outcome. And finally, payer reimbursement. By having return on investment data readily available, you can see what would be the benefit of allocating dollars for one intervention versus another in relation to mental health and substance use disorder services. And in total, these measures are also actionable so that you can create and embed feedback loops that will allow clinical practices to move towards continuous quality improvement and performance improvement. The measurement-based care core measure supplement came from the demands of individuals that helped to create the measurement-based care issue brief. And this is really designed to fill the gap in payers, providers, other stakeholders that wanted to say what measures could we use. And this actually came through a lot of the pre-webinar questions as I was screening through them. This supplement includes tools for adults as well as for child and adolescent patients, for mental health disorders as well as substance use disorders, and provides a set of core outcome measures that will be suitable for inclusion in measurement-based care. Some of the recommendations here are that payers should use measures that are clinically useful, that are time efficient, and that enable monitoring of aggregate data on quality and population health. So we're not saying you need to use these measures. There might be comparable ones that you have developed or have heard of. They need to share these characteristics. And for payers that are interested in incentivizing measurement-based care, it's also really important that you account for the case mix in different populations based off the severity of their condition and their diagnosis as well. So not to propose rigid outcome measure thresholds and time payment to that in a rigid way, but accounting for case mix variation. So I'd just like to close to comment on the fact that we believe that this is coming, the future is coming in terms of the expectation that measurement-based care will be the way in which we provide these services both in primary care and specialty care settings. We already know that the National Quality Forum and NCQA continue to expand behavioral health measures and include them in their new guidance. The American Psychiatric Association's Council on Quality is also actively engaging discussion on measures so that the provider professional organizations can also weigh in to see which measures we support. And the Joint Commission will likely move their standards to measurement-based care in 2017, so we can look forward to that as well. And finally, MACRA is another recent example of how measurement-based care is expanding to all providers. So I think I'll close there and turn it back over to Catherine.